Good evening, everyone, and welcome to the series of webinars you've been seeing and listening for last many months. And today we have an extremely important topic, which is we've seen a lot of these patients during the COVID epidemic, and now we have other viruses also. They keep on coming, and now and then we always have people who are suffering from viral infections. And we as chest physicians encounter these many of these patients and viral pneumonias. And many a times it's very difficult to differentiate whether it is a viral pneumonia or a bacterial pneumonia. In fact, both of them are together many a times. And sometimes they can get very severe, result in ARDS, going on a ventilator, and may not have a good outcome. So this is a challenge. So today, in next 2 hours, we are going to discuss everything about viral pneumonia. I'm Dr. Rajesh Chawla, Senior Consultant, Respiratory and Critical Care Medicine, Indraprastha Apollo Hospital, New Delhi. I have been the President of Indian Society of Critical Care Medicine, National College of Chest Physicians, Chancellor of Indian College of Critical Care Medicines. So this is a topic very near to me. And I think before we discuss among all these experts who are there, they are very expert and they have a lot of experience in managing these patients. We'll have a talk in the beginning by a very eminent pulmonologist who is very well known. And, when I was seeing his CV today, I felt very inferiority complex. So he's got 500 publications and H index of 80. So, and he probably must be among the 1% or 2% of the world researchers. He's been the former director and professor of pulmonary medicine at the SCIM National Technical Expert on Asthma and COPD. And he's looking after now the Lung India. And without wasting any time, I hand over to Dr. Parvaiz to talk about viral pneumonia. He will give in next 20-25 minutes, tell us about the various aspects, and then we'll discuss in detail. And we can also take your question, which you can send it to us, and we'll take in between the discussions. So over to Dr. Parvaiz.
Thank you, Dr. Chawla, for that very kind and generous introduction. And thank you, ICS, for having me as a part of today's program. I'll share my slides. Okay, so I've been tasked to talk on viral pneumonias and an overview before the final panel discussion goes into the process. I'll talk about viral pneumonias, and I'll start off with a case. It was a 52-year-old previously healthy lady was referred for a progressive respiratory failure following a febrile illness, and she was admitted to the ICU. The X-ray of the chest revealed bilateral infiltrates with a normal cardiac size. This was the CT showing bilateral ground glassing, consolidations bilaterally. The blood counts were normal, CRP was normal, procalcitonin levels were normal. Patient had a mild renal failure. There was no evidence of a disseminated intravascular coagulation. D-dimers were normal. Sputum was negative for A or B bacteria and fungi. Patient was empirically started on oseltamivir and IV broad-spectrum antibiotics. He was given supplemental high-flow oxygen. Blood cultures and urine cultures returned negative. The RT-PCR for SARS-CoV-2 was negative. The RIDIT, the Rapid Influenza Diagnostic Test, as well as the RT-PCR for influenza A was positive, and the subtyping revealed an AH3N2. Blood gases revealed ARDS. Patient was intubated and mechanically ventilated. There was a gradual improvement. He was weaned and extubated on day 7. There was a clinical and radiological improvement. Subsequently, he had no residual illness and discharged home. So this was an example of a garden variety of influenza pneumonia. This is the slide showing the causes of death. It was basically under the auspices of the Global Burden of Disease that looks at the epidemiology of disease the world over. It is spearheaded by the Institute of Health Metrics and Evaluation by the University of Washington. And we published this data this May. We showed the causes of death in the world in 2021, and this is the data from India. As you can see, despite what people kept on harping on, COVID-19 contributed to around 14% of the total deaths in 2021, followed by ischemic heart disease and stroke. So COVID was the number one killer in India in 2021, whereas worldwide it was number two killer. So that gets us to the viral pneumonias. Which are the viruses that actually cause pneumonias? There are lots of viruses that can cause pneumonia, primarily the RNA viruses like the respiratory syncytial virus, the rhinovirus, influenza A, B, and C, human metapneumovirus, parainfluenza viruses, and human coronaviruses. RSV is the most common cause of viral pneumonia in small children and infants. Rhinovirus generally causes an upper respiratory tract illness. It is not commonly recognized as a cause of viral pneumonia. Influenza A and B can cause pneumonia. C causes a mild upper respiratory tract illness. Human metapneumovirus is again a novel viral pathogen that is increasingly getting recognized as a cause of viral pneumonia. Parainfluenza viruses again are RNA serotypes and can cause pneumonia-like illness, usually in young children and especially during the spring and fall seasons. Whereas human coronaviruses have been SARS, MERS, or other coronaviruses that have predominated previously before before SARS-CoV-1 or SARS-CoV-2 came into recognition. They have been there for a long, long time. Then we have adenoviruses, like it's a DNA virus. It is usual in patients who have solid organ transplants or hematological transplants. Enteroviruses, again, RNA virus, primarily cause polio and gastrointestinal illness and can occasionally cause an upper respiratory tract illness as well. Varicella zoster virus causing chickenpox in the younger children and adults, adolescents, and shingles in the old ages once there is a reactivation of the dormant or the varicella zoster vaccine. It is can cause pneumonia and is usual in non-immune pregnant women, non-gravid adults with chickenpox. It's a fairly common cause of pneumonia in patients with HIV and has been associated with post-shingles outbreak. Hantavirus is again zoonotic viral pathogen that can result in pneumonia. Then we have EBV virus can also be associated with a viral pneumonia and can be seen in patients who have associated hematological dyscrasias. Herpes simplex virus can cause a pneumonia in patients who have an immune compromise like HIV or solid organ transplantation or hematopoietic transplantation. CMV can cause a pneumonia in people who have a low CD4 count, like in patients with HIV, and measles at times in young children can lead to a pneumonia in patients who have a childhood exanthem and can lead to a viral pneumonia as well. Sometime back, we looked at the microbial etiology in hospitalized North Indian adults with community-acquired pneumonia. 225 patients were seen who were admitted. And apart from the routine microbiology that we did, we also looked at their serology and urinary antigen for chlamydia, mycoplasma, legionella, and pneumococcus, and also did RT-PCR for influenza. That was a single viral pathogen that we looked for. And this was the result. Number 3 pathogen in the causation after streptococcus pneumonia and pneumophila was influenza. Influenza contributed around 15% of the total etiological agents that were retrieved in our patients with community-acquired pneumonia who were hospitalized. Shifting gears a little bit, we all see patients of chronic obstructive lung disease, and we know that they have their life course punctuated by exacerbations, and these exacerbations are earth-shaking events. We looked at these patients as to how many of them survive after they are discharged from the hospital after an exacerbation, and this was a horrifying data that we found that patients, nearly 40% of them are dead at 2 years. So as the gold staging, and that time this was gold stage 4, the worst the stage, that is stage 4 patients, were nearly dead. Most of them were dead by the age by 2 years of the discharge. So it's a very, very bad disease that develops, acute exacerbation of chronic obstructive disease. But why am I talking about AECOPD today? This is the reason we wanted to see as to whether there's a contribution of influenza to acute exacerbation of chronic obstructive lung disease that we see very often in our patient, in our OPDs and our wards. And this is what we found, that 40 of the acute exacerbations could be attributed to influenza H3, H1N1, and B. And patients with influenza were more likely to die with an odds ratio of 3 times during hospitalization. What about other viruses? We looked at the acute exacerbations of chronic obstructive lung disease and found that, consistent with the seasonality, during winters, we found that there was an increase in the retrieval of viruses from the respiratory tract once we looked for these pathogens. And these contributory viruses including influenza A, influenza B, Boca viruses, coronavirus like 229E and OC443 and NF65. Talking of respiratory syncytial virus disease, that is a very common disease in children, and we looked at around 4,000 plus respiratory illness admissions who were seen for a 2-year period, who met the case definition for severe acute respiratory tract infections. Amongst the enrolled patients, 256 were 62% were positive for any virus. And RSV was the most commonly virus detected, that was 29%, followed by human rhinovirus, that was 21%, PIV 8%, influenza viruses 4%, Boca virus 4%, coronavirus 4%, adenovirus 3%, and human metapneumovirus 2%. So RSV was a frequent detection in patients who were less than 5 years of age, and mostly they were of type B on phylogenetic analysis. There's another data study where we looked at 16,000 plus patients of respiratory illness, 8,000 plus of acute respiratory illness, and 7,000 plus of severe acute respiratory illness. And we detected respiratory viruses in around 33% of patients, and multiple viruses were seen in around 3% of the patients. And among both ARA as well as SARI, influenza contributed to about 12 to 15% of the most frequently detected viruses. However, in another study that I was part of, that's called the GRIMP study, which looks at the pathology, the etiology of pneumonias across the globe, we tried to find out what's the frequency of testing for viruses as a percentage of all tests performed in each country. And as you can see that the Europeans test a lot for viruses, whereas not many other countries do test for viruses. And when we look at the percentage of influenza virus in relation to all-cause viral community-acquired pneumonias, you can see that 14% of the patients with community-acquired pneumonia underwent a nasal swab. Viral community-acquired pneumonia was diagnosed in 28% of these, and influenza virus, depicted here in red, was isolated in 80% of these. Testing frequency and viral community-acquired pneumonia prevalence were inhomogeneous across the participating centers, as I showed you in the earlier slide. This is one patient that we saw some time back, and we had found a patient who had a diffuse chickenpox varicella rash and had a pneumonia associated, and we attributed it to a varicella pneumonia. So looking at the epidemiology of pneumonia causing viruses, who is getting affected? Generally the very young and the very old. Patients who are pregnant have a definite predilection for a worse outcome because of a viral illness, because pregnancy is a hypersteroid state and you are sort of immunocompromised. Then patients who have an immunocompromise, they are more prone to developing viral infections. And those who have comorbid conditions like trauma, severe burns, uncontrolled diabetes, malnutrition, poverty, environmental exposures, and group livings. Living in lower middle income country itself is one of the factors for severity of influenza related hospitalizations, as we found in this study called the GIHS network. And we found that there was a sevenfold increase in the risk of influenza-related ICU admissions in lower middle income countries compared to high income countries. And there was also a higher risk for mechanical ventilation and in hospital death, and it increased by about 4%. So how do we get it? We get either a direct inoculation of the viral particle into the lungs, be it RSV or influenza. It can also spread in a contiguous fashion from viral infections near the upper respiratory tract, like measles. And there may be a hematogen spread from a distant viral infection like CMV. The target cell of the virus is the pneumocyte, which results in inflammation and alveolar damage. And then a series of processes happens, which leads to inflammation, secondary edema, microhemorrhages, cellular immune reactions, and they lead to recruitment of various inflammatory cells, release of fibrin. Both CD4 and CD8 lymphocytes are involved. It leads to a cascade of immune product secretions that end in increased vascular permeability, inflammation, and resultant edema. There can be an intra-alveolar organization and an obliterans-like clinical picture. And at the far end of the spectrum, there can be an interstitial pneumonia, pulmonary edema, and cardiogenic shock. So how does a patient present to us? There is nothing in history that is pathognomonic of a viral etiology. Generally, they have a gradual onset as opposed to the sudden onset of symptoms in bacterial pneumonia, but this is not a hard and fast rule, because sometimes there can be a rapid deterioration in a patient with influenza or COVID, as we have seen during the COVID pandemic. There may be a prodrome of a viral upper respiratory tract illness before the person comes up with pneumonia. Temperature may be lower as compared to bacterial pneumonias. There may be a history of HIV. Patient may have concomitant flu-like symptoms. There may not be a prevalent sputum. There may be a history of solid organ transplantation or hematopoietic transplantation. Concomitant GI symptoms might be there. And of course, there may be a history of immunosuppression or neoplasm. No physical finding is pathognomonic of a viral etiology. However, if we have clinical findings that are out of proportion to the temperature, like tachycardia or tachypnea, which is out of proportion to temperature elevation may be sometimes disproportionately low compared to the debility level that the patient has. There may be a concomitant upper respiratory tract infection. Patient may have a rash. The paucity of physical findings on pulmonary examination is disproportionate to the level of debility, and sometimes you can have bilateral positive lung findings. On evaluation, once you evaluate a person with a viral pneumonia, we do a CBC. CBC can show a leukocytosis, a normal leukocyte count, or even a leukopenia. So what is generally thought of is that you cannot have elevated WBC count. That is not entirely true. It can be there. However, it's relatively less common, and a left shift of polymorphonuclear leukocytosis is generally not seen. Chemistry panel can be useful for gauging the degree of hydration. You have a relatively renal dysfunction, and you can get an idea about dosing of renal excreted medications for using in these patients, and for that you need to get a kidney panel. C-reactive protein, as I already said, can be elevated because of it being an acute phase reactant, though this is not a specific or a sensitive finding. Rapid antigen tests can be positive, and they are available for many infections like RSV, influenza A and B. We have for COVID, HSV, and CMV. Gene amplification, which is being routinely used now for many of the viruses, specifically for coronavirus and influenza viruses, by using an RT-PCR. Cytological evaluation, DNA viruses, it's not routinely practiced, but DNA viruses typically produce an intranuclear inclusion, whereas RNA viruses produce an intracytoplasmic inclusion. Viral cultures are gold standard, but have limitations because it takes a lot of time for the viral cultures to return positive. And once you are dealing with a pneumonia patient, you don't have that kind of a time available to you. Radiology helps, but it is not pathognomonic. You may have alveolar infiltrates, lobar consolidation, nodular densities, and pleural effusion in bacterial pneumonias, whereas in viral pneumonias, there are interstitial infiltrates, patchy distribution of interstitial infiltrates, bilateral infiltrates, pneumonia-like syndrome with an unremarkable chest X-ray can be there. CT has become the fashion of the day. Everybody goes for CT before even for X-ray chest. So you can have central lobular nodules, which can be acinar or airspace nodules, 6 to 10 millimeters in diameter. Best seen in early disease, can be seen up to 7 to 80% of viral pneumonia cases. There may be ground glass attenuation with a lobular distribution, segment consolidation, and or ground glass attenuation, which can be diffuse with thickened interlobular septa. Coming to the treatment, treatment is generally supportive. We have a supportive care, and it is oxygenation, maintenance of hydration, either via supervised oral intake or intravenous fluids, maintaining rest and reducing the oxygen demand, maintaining the increased calorie needs of the patient, which is there secondary to the increased respiratory effort. Treatment of with antivirals and antibacterials is usually co-administered because we have always a risk that the patient might have a superimposed bacterial infection as well. Influenza virus can be treated by oseltamivir, paramivir, and zanamivir. The viruses that we have in circulation about influenza are generally resistant to the adamantines. That is why we don't use amantadine extra now. RSV can be treated by ribavirin. Ribavirin is also useful in parainfluenza viruses, adenoviruses, and measles virus. Herpes simplex infection can be treated by acyclovir, and ganciclovir or foscarnet for CMV, and varicella zoster can be treated by acyclovir, famciclovir, or valacyclovir. Another slide from the GLIMPS study, where they found as to how many of the patients are empirically treated with oseltamivir. This is all the patients, and most of the patients are negative for influenza. And of these 23% who were positive for influenza, half had actually been put on oseltamivir empirically, and half had not been given. Another area which is of contention is use of corticosteroid treatments, and this was one of the studies from Taiwan, which was published last year in the Journal of Microbiology, Immunology, and Infection, looking at the outcomes of corticosteroid treatment in critically ill patients with respiratory viruses-related community-acquired pneumonia. And this is what they found, that the 14-day, 28-day mortality in patients who were more than 70 years of age was not different. However, those who were less than 70-year-old, there was a benefit related to corticosteroid treatment. So non-elderly patients with severe respiratory virus-related community-acquired pneumonia were more likely to benefit from corticosteroid treatment than elderly patients. And these are the IDSA guidelines on the treatment and management of patients with COVID. And the recommendation is that among hospitalized critically ill patients, and I'm going to define critically ill patient as somebody who's on mechanical ventilation or an ECMO, or he has evidence of an end organ dysfunction as seen in sepsis or septic shock. And in COVID-19, the most commonly reported form of end organ dysfunction is ARDS. So there's a strong recommendation with a moderate certainty of evidence, and dexamethasone is to be given rather than no dexamethasone. And if it is unavailable, you can give alternate glucocorticoids like prednisone, or other steroids can be used. Among hospice patients with severe but non-critical COVID-19, the EDSA guideline panel again suggests dexamethasone rather than no dexamethasone. And severe illness is defined as somebody who has an SpO2 of less than 94%. Among hospitalized patients with mild to moderate COVID without hypoxemia requiring supplemental oxygen, IDSA guidelines suggest against the use of glucocorticoids. So patients who have severe or critically ill patients with COVID are the ones who have been recommended to receive steroids. And we know that COVID leaves a residue, and this can be also seen in other viral illnesses like the H1N1. This is what we described post-COVID lung fibrosis. This is one of the patients in July 2020 who had a severe COVID pneumonia, and over time, in about a month plus time, he developed features suggestive of a diffuse interstitial fibrosis. So, COVID can actually have a reversal of the fibrosis, which can be seen in most of the patients. It can stay static, which is less common, or it can worsen progressively, and that may lead to a respiratory failure over time. So, lung transplantation can at times be the only viable treatment option for patients with severe, irrevocable COVID associated ARDS or subsequently post COVID fibrosis, and has shown promising short term outcomes. COVID related respiratory failure lung transplantation requires strict patient selection, and extensive lung transplant evaluation has got to be done. These respiratory failure related transplants are complex and should be done at centers with a reasonable bit of experience, preferably at high volume centers with multidisciplinary teams. Complications of viral pneumonias can be concomitant bacterial infection, which can result in abscess, empyema, or a pleural effusion. There may be sepsis with secondary multiple organ failure, acute respiratory distress syndrome, acute respiratory failure, cardiovascular collapse, or post-viral, that is post-COVID, and post-H1N1 fibrosis has also been reported. There's an update on the management of adult patients with ARDS, and ARDS in COVID or other viral infections is pretty much treated the same way as other ARDS, and we have a strong recommendation in favor for prone positioning, lung protective ventilation with low tidal volumes of around 6 ml, 4 to 6, with plateau pressures of less than 30. There's a conditional recommendation in favor for systemic corticosteroids, high PEEP, ECMO, and neuromuscular blockade only in severe ARDS, and a strong recommendation against prolonged recruitment measures and high frequency oscillatory ventilation. Prognosis depends on the etiological agent. Like some etiologies have a worse prognosis than others. Like COVID has a worse prognosis than influenza. Hantavirus, SARS, or MERS carry a much worse prognosis than RSV or influenza. Patients with immune compromise have a worse prognosis. Underlying pathologies of the patients, like underlying cardiac or respiratory disorders, diabetes, cancer, greatly increase the anticipated morbidity and mortality. Presence of an concomitant bacterial infection worsens the prognosis, and the relative point during the infective process at which diagnosis was made and definitive treatment, if available, started also impinges on the prognosis of the patient. And then we have vaccines available against some of the viral pathogens and can be used to prevent ourselves, especially the high-risk ones, from getting a viral illness. So the take-home is that the role of viruses in primary pneumonia is increasing, and viral respiratory pathogens are increasingly getting recognized as a cofactor in bacterial pneumonias, secondary to increasing prevalence of immunosuppression, cancer treatment, organ transplant, and HIV. Prevention, especially in the form of immunization, can greatly, significantly decrease the incidence of viral pneumonias. Increasing specific and sensitive real-time diagnostic lab tools in the form of ELISA and PCR modalities for specific diagnosis of viral pneumonia and assignment of specific treatment when existent. Although there are no pathognomonic history or physical findings for viral pneumonia as opposed to bacterial pneumonia, there are a number of clinical clues that might give you some suggestion that the person has an underlying viral pneumonia. And although specific viral agents do exist, the cornerstone of treatment remains supportive care. Thank you for your kind attention.
Thank you, Dr. Parvaiz, for giving such an excellent overview of management of viral pneumonia. So thank you very much, everyone who has joined us in this evening webinar. And don't worry, we are going to discuss everything in a little more detail. And if you have any question related to this, please put in the chat box and we'll definitely take it whenever it is along with the flow, or otherwise also we'll take your questions. And I have a well-known panelist on the, so Dr. Salil Bhargava, who is professor at HOD MGM Medical College, Indore, very well known, very active uh, in the society, in the Indian Chess Society, as well as in NCCP, API, and he's going to be the one of the panelists. And he's member of the editorial board of Lung India and Indian Journal of Tuberculosis. Next slide, please. So the other panelist is Dr. Binu Krishnan, who is from Trivandrum, and he's, as you can see, he's fellow of American College of Chest Physicians, and he's presently attached to the PRS Hospital Trivandrum as a senior consultant pulmonologist, and very active man, and he's also going to talk on various aspects of viral pneumonias. Next, please. Dr. Tanvi Bhatt, she's consultant pulmonologist at the Zainova Shalby Hospital, Mumbai. She's the ex-assistant professor. So she's the young budding pulmonologist who will tell us about the various aspects related to this topic. Dr. Nisha, he is currently with the SRK Hospital, Trivandrum, as a consultant pulmonologist. So I have a lot of young as well as the experienced person who are going to tell us about the various aspects of the viral pneumonias. Next, please. So thank you very much. That's me, Dr. Rajesh Chawla. I'm senior consultant respiratory and critical care medicine at Indraprastha Apollo Hospital. I've been very active pulmonologist and intensivist, and have been the president of National College of Chest Physician, Indian College of Critical Care Medicine. I've been the past chancellor and past president of Indian Society of Critical Care Medicine. So without wasting much more time, so I will start with Dr. Salil. So Dr. Salil, I did not give him the chance to introduce me. So what are the common viruses that cause pneumonia? Although Dr. Parvaiz had beautifully told us the various viruses, of course, all of us know only about the COVID and influenza. So just tell us, and what is the clinical presentation, and does it really differ as far as the presentation is concerned from bacterial pneumonia?
Thank you. Thank you, Dr. Rajesh.
Louder, please.
Yeah. Thank you, Dr. Amita, giving me the opportunity to share my views as a panelist. Before I start, Rajesh has not given me the chance, but let me say he has written a book on NIV, which I have read almost good number of years back. And he's a great critical care expert. He has been participating here and there for critical care. Thank you, Rajesh, for being the moderator in the panel. Let us come to the business. Yeah. So you asked me what are the common viruses. Dr. Parvaiz has very nicely depicted about, but for the sake of those who have slightly joined late, let me repeat the viruses. We have heard respiratory syncytial viruses and influenza A, B, C viruses. They are there. SARS coronavirus, other coronaviruses, rhinovirus, parainfluenza virus, adenovirus, human metapneumovirus, human vocavirus, enterovirus, even varicella zoster, hantavirus, and Epstein-Barr virus, human herpes virus, cytomegalovirus, measles, they all can cause, along with their infections, pneumonias. So it is, yes, it is there. 50% of the patient may have viral pneumonias. And your next point was, what is the clinical presentation with viral pneumonias? That is, again, that has been discussed well with by Dr. Parvaiz. It is slightly overlapping things as far as bacterial and viral pneumonias are concerned. It may range from mild pneumonia with fever, cough, and shortness of breath to severe pneumonia. It can range anywhere with sepsis and respiratory distress. And the symptom severity depends how the individual's local and systemic immune response is there. So depending on that, as we have already discussed, that the patient, it is very common with hematological malignancy or other malignancies, solid organ transplant, those who are on steroid or steroid therapy or immunosuppressed diseases, they are there. Usually, there may be a non-productive cough, dyspnea, And pleuritic chest pain sometimes may be there along with all these. Fever, chills, fatigue, malaise, anorexia, they can also be there accompanying these patients. These patients may have tachypnea and hypoxemia, which may be visible also. Sometimes worsening hypotension, altered mental status may be there along with these pneumonias. And there may be other signs of organ dysfunction which may be visible depending on the severity, like renal disorders, liver disorders, thrombocytopenia, and there may be coagulation disorders along with all these things, they can be there. So it is slightly difficult to differentiate between viral and bacterial pneumonia, but there are few things: dry cough, pleuritic chest pain. There may be purulent sputum, which may be more common with bacterial infections, although they are overlapping, but we can try to understand up to some extent whether this is a viral or a bacterial pneumonia. Okay,
Thank you, Dr. Salil. So, there is a large number of viruses. After this biofire being available, you do isolate a lot of viruses causing. But even today, the COVID, we do see sporadic cases of COVID-19, the influenza. These two are the relevant to physicians, which we are able to diagnose and treat. But many a times, it is viral, but you've not isolated the virus, and probably because they started like an upper respiratory tract symptoms. When a patient starts with upper respiratory tract symptoms, even if it worsens, and then the worsening will depend on a lot of other factors. Like Dr. Parvaiz said, young and the old, they will have more severe symptoms, and they may develop up to a multi-organ failure, respiratory failure, and this very few patients fortunately develop these symptoms. And as far as on the basis of symptom, it is very difficult to differentiate, except for the upper respiratory tract. And then sometimes the blood reports and X-ray come to our RSU. So that's the next question I'm going to ask Dr. Binu. In what way do the blood report and chest X-ray help to differentiate between viral and bacterial pneumonia?
Good evening, and thank you, Rajesh Chawla sir and Amita ma'am, for giving me this opportunity for this wonderful CME. Now, coming straight to the question, it's about the radiological as well as the hematological. So first, I will discuss the radiological. X-rays, I'm very sorry to say that it's a highly non-specific thing in differentiating the etiologies between bacterial and viral, because we may see some shadows and we may not see some shadows at all. So X-rays are practically very non-specific, but CT imaging, that will provide very detailed information with different types of patterns. And to differentiate from viral and bacterial, in the viral, usually the centrilobular nodules will be there, some micronodules will be there, some tree bud appearance will be there for most of the virus, like influenza, para-influenza, RSVs and all. And another common finding in CT will be the ground glass opacities, which is very common in viral. But coming to the bacterial, if you are seeing a consolidation in the initial stages, it is more in favor of a bacterial rather than a viral. And then there are the shadows like reticular shadows, or what we call the interstitial shadows, which are more common in the viral and the bacterial. And the feature is that if it is a multifocal or if it's a bilateral peripheral opacities, then there is more chance to progress to a respiratory failure, which requires a mechanical ventilation and poor clinical outcome. So the multizonal as well as the bilateral peripheral opacities have tendency to progress towards a respiratory failure. That's regarding the radiology. Now coming to the blood parameters, the clinical specimens which are suitable for diagnosis are in the order of priority ideally it should be bowel fluid, then nasopharyngeal swabs and sputum. And blood comes next. And in the blood, for the viral, what we usually see is there are so many small lymphocytes are there at the site of lung injury. So what happens is, due to the cytokine-induced lymphocyte sequestrations, the lymphopenia occurs in most of the virals. And the coagulation as well as the fibrinolytic pathways are activated in viral infections, which lead on to increased incidence of hemorrhagic as well as the thrombotibular. Cardinal features of viral are: one, it should be a leukopenia, lymphopenia, and thrombocytopenia. And these are said to be the markers of severity of viral illness. And the prothrombin time as well as the APTT, because the fibrinogen and the procollagen pathways, they are activated. So PT and APTT tends to be prolonged. And we have seen the COVIDs that the D dimers, they are usually elevated. These are the things which are usually different in both bacterial as well as the viral.
Thank you, Dr. Binu. You see, as far as the when you want to differentiate on the basis of the X-ray, and X-ray may be absolutely normal and patient may be very sick. This is, and that's where what he said, you get a CT and you will be surprised. There are a lot of shadows, ground glassing, and some consolidation also you may see, because sometimes the X-ray chest is not very sensitive, but otherwise you can see lobar consolidation, interstitial shadows, the bilateral, patchy, bilateral, even lobar consolidation also. So nodules, as he said. So you can see all of these, but it is the chronology, like he's presented like an upper respiratory tract and is getting sick, and it is the epidemic is going on, it makes things easier. If it is not going on, then probably you don't suspect that often. And as far as the blood report concerned, if the TLC comes normal, you think probably I'm dealing with a viral than a bacterial. Most often bacterial may be normal, but they are high. And then many a times you get a CRP, which could be high in any inflammatory disease, even in a non-infective also. It is a very non-specific. But when you are thinking, it helps you. Procalcitonin may be negative in viral. So these are some of the things which may help to shortlist that probably you are dealing with. And rest of the complications, multi-organ failure, they will all be similar. So now let me ask Dr. Tanvi. So what are the tests, if you're thinking of viral, you advise in a patient suspected of having a viral pneumonia?
So initially we do the regular test, as we spoke about the blood evaluation and the radiological evaluation. When we want a confirmed diagnosis of what pneumonia we are dealing with, we send a nasopharyngeal swab and we do a molecular diagnostic test. The best and the quickest available is the PCR-based technique, which usually isolates most of the common viruses like influenza, parainfluenza, coronavirus, human metapneumovirus, rhinovirus. Viruses like human metapneumoviruses are newer detecting viruses, which we are seeing in COPD patients. Such viruses may not be causing severe illness in young patients, but in patients with chronic respiratory illness or cardiac problems will have a severe viral infection and ARDS because of these. Next will be the cytological evaluation, where we can see the inclusion bodies, or histopathological evaluation, but that is again not possible in a patient who is intubated and having ARDS. Also viral cultures, but again it becomes bookish because till the time we get the report, the patient will be suffering a lot. So the basic test becomes a PCR-based technique and rapid antigen, which we have mainly for COVID.
So go ahead.
Next. Also next, the question comes whether to take a upper respiratory tract or the lower respiratory tract. So upper respiratory tract, when we take the nasopharyngeal swab, it gives equal and best results rather than waiting and posting a patient for bronchoscopy and getting a lavage and sending PCR test for that.
Okay. So basically, the RT-PCR, which fortunately is available for COVID-19, it's available for H1N1, it is available for herpes, even as Dr. Parvaiz said, for CMV and other viruses, depending on center to center, these are available. They are quick, in few hours, they can give you the result. And when it is the cases, the large number of cases are going on and you think it is viral. So I think these tests can really help you. And when you are suspecting viral, do not wait for the test report. If you suspect, start the treatment and then you can modify once you get the result. So now my next question is to Dr. Nisha. ARDS we know is, or the respiratory failure, is a very common complications of any viral pneumonia, very commonly, particularly the influenza A or the H1N1. which you see, or even the COVID-19. But what are the other complications you see more often in viral infection, Dr. Nisha?
First of all, thank you, ICS and Amita ma'am, for having me here. Now, going to the non-ARDS complications of viral pneumonia, first thing is secondary bacterial infection. The patient is already immunocompromised. So, infection control measures should be strictly followed. That is following all the ICU bundle care, that is WAP bundle, COTI bundle, and indwelling catheter bundle care. And this is about the infection. Next is sepsis and septic shock, which might lead into secondary organ dysfunction. That is, here the most important thing is the optimizing the fluid. Fluid hydration is very important here, especially when the patient presents to you. That is, the ROSE approach can be applied for the fluid management. And if our aim is to maintain a mean arterial BP of more than 65 mm mercury and a lactate of less than 2. If you're unable to maintain this with enough fluids given, go in for inotropes or vasopressors. And then the next is cardiovascular complications, where you can have cardiogenic shock, arrhythmia, even MI and myocarditis, especially in case of viral pneumonia. So in cardiogenic shock, you can start the patient on inotropes. And in case of arrhythmia, you can address the arrhythmia, or distal arteriotomy also has to be addressed. And next is critical illness myoneuropathy and diaphragm weakness. We'll consider these together. That is, a main goal should be for early weaning. That is, daily go for SBT and SCT trial, that is spontaneous breathing trial and spontaneous awakening trial, and look for readiness of the patient to get extubated. And also bring in patient's effort in respiration so that diaphragmatic weakness can be prevented to some extent. And then limb physiotherapy is very important to prevent muscle disuse atrophy. And then you have a very important DVT, because the patient is bedridden. So DVT is very commonly seen. So you have to go in for a pharmacological thromboprophylaxis. If there is a contraindication to initiate a pharmacological thromboprophylaxis, go in for a mechanical thromboprophylaxis. Then for GI bleed, you can start for stress ulcer prophylaxis. And then I think one more important thing to be added is antibiotics to watch, because emergence of resistance is also a complication of treatment of pneumonia. So look for opportunities for de-escalation of antibiotics whenever possible. So compiling all this, I think the fast hugs bit which we follow in our ICU should be religiously and very seriously followed, so that most of these complications can be prevented.
Yeah, thank you, Dr. Nisha. So, basically people who have joined late, we're talking about viral pneumonias. They present like upper respiratory tract, and then they can involve the lower respiratory tract symptoms. And then you do an X-ray and blood test, which sometimes is not easy to differentiate them from the bacterial pneumonia. What Dr. Nisha said, they will present as a multi-organ failure. Fortunately, viral infection restrict to the lung. Some like H1N1 or COVID-19, most of the patient will restrict to lung. And the patient who restrict to lung, they have a better prognosis. But they have a propensity to develop a multi-organ failure. So whichever organ they develop, you have to give them support. So if there is a neurological involvement or the cardiac involvement or the GI involvement, so you have to manage and give specific support. And many a times you have to involve the other specialties to manage these patients as a joint team to treat these patients. So, we have talked about the symptoms, we talked about the test, we talked about the RT-PCR. Now the point comes, the specific treatment for viral infections. So Dr. Parvaiz, you heard, he's talked about, so I want to listen from him again that how do you treat, or what are the antiviral treatment which are available? I mean, all of us have only heard about oseltamivir, which is used tremendously. What are the others, and what are the indications in a specific virus, and doses wherever possible, Dr. Parvaiz?
So, thank you, Dr. Chawla. Antiviral drugs are actually effective against the various phases of the life cycle of a virus. We know from the attachment to the cell to its replication inside the cell, and then subsequent exit from the host cell. So the virus can attack, and the antiviral agent basically can be an attachment inhibitor. It can inhibit the entry of the virus into the cell. Those are entry inhibitors. They can affect the uncoating of the virus, that is protease inhibitors. Then there can be something that can prevent the integration into the genome of the host cell, that is polymerase inhibitors, nucleoside and non-nucleoside reverse transcriptase inhibitors, and integrase inhibitors. They're general antivirals. However, for antivirals that are particularly important for us, the pulmonologists, when we talk of the respiratory infections, we are talking generally confronted with COVID and influenza. And for influenza, the antivirals that are available are as neuraminidase inhibitors, and they are, as you said, oseltamivir, peramivir, and zanamivir. Oseltamivir is available and is being used right, left, and center, and its best use is within 1 day of the initiation of the illness. However, it has been shown that even if it is given up to 5 days after the onset of the illness, it may still confer some benefit. Zanamivir has an advantage of an inhalational form and can be given inhalationally as well. Peramivir is used in certain countries, but not very commonly in India. But though I was a part of the peramivir trial, they prematurely aborted it in India. The other anti-influenza drugs like adamantines, that is amantadine and rimantadine, are unfortunately the influenza viruses that are in circulation are resistant to adamantines. As a result, that we don't use these amantadines and rimantadines anymore. Talking of ribavirin, it is useful in RSV, which can be very serious, causing bronchiolitis and pneumonia in infants. And ribavirin was used for a long time, but the efficacy has questionable, and there are studies that have shown that it is not that very effective, and as a result, it has gone into some kind of a dispute. Ribavirin also has been found to be effective against other viruses like parainfluenza virus, HMPV. Then against coronavirus, we know that remdesivir came as a big relief to us for Ebola as well as for this SARS-CoV-2 during the COVID pandemic. For herpes or varicella, we have acyclovir, famciclovir, or valacyclovir, and they are usually given. I mean, oseltamivir and zanamivir are generally given for 7 days, whereas whenever you are confronted with herpes pneumonia, the drug treatment has got to be continued for about 10 days.
Thank you, Dr. Parvaiz. So he's given a brief overview of the antiviral treatment available. Now, oseltamivir, which we use for H1N1, normally use 75 BD for 5 days. That's the usual. But in a sick patient, you can, although there are not many studies, but we are in a tendency to use 150 milligram twice a day, and many a time extend up to 10 days also in a severe. We really don't know whether they are required, but that's the usual common practice, 5 to 10 days of 150 in a patient who is on a ventilator or on a non-invasive ventilator.
So, I mean, the sense about this practice is that they say that their viral load might be higher in patients who have an immunocompromise. And as a result, because in these patients, there is a prolonged shedding and prolonged replication of the virus. And as a result, you want to hit hard and hit prolonged. And that is why you want to give a higher dose, and maybe you increase the duration of your treatment.
The other very important thing is don't wait for the report if you are suspecting. You can always stop it, because earlier you give, the better, because it stops the multiplication. If it is all the damages has been done, ARDS is developed, then it's not going to help you that much as if it would have helped if you had given early. So now even the surviving sepsis guideline also recommends that if you are suspecting that patient to have a viral pneumonia, you can start whatever the oseltamivir, and then probably once you get the report as negative, you can always stop, or you have an alternate diagnosis, because you should not lose the time, and it is quite scientific. Dr. Salil, okay, we are treating viral. Can they be prevented? Can you suggest how they are prevented, in fact?
Dr. Chawla, you were talking about...
Louder, your voice is little less.
I'm sorry. Is it okay now? Yeah.
Yes.
So we have to anticipate in which groups it can be there. As I'm just continuing what Dr. Parvaiz was talking about. Because if you anticipate the various groups which can be there, particularly in the first wave of when H1N1 was there in 2009, whenever a pregnant lady or an obese person with BMI 35-40 was coming to our wards, we were already keeping our hands crossed. So these are some of the groups where we have to anticipate the problem can be there. And apart from this, comorbidities, if it is there, elderly living in long-term nursing care, and with so many associated comorbidities, they are the groups where we should take care and we should try to prevent them as far as possible. And we already know we have used the virus during COVID. We have used vaccines. Influenza vaccine is available since 1940, and now it is available. And we have been asking in most of the countries, it is given as a flu shot. Everybody gets it, but in India, it may not be possible. But influenza vaccine should be used. It's a very useful thing. In fact, now the season is there. We say from Kashmir to Kanyakumari, every state is suffering from URIs once, or either in a big way or in a smaller way. They may land into pneumonias. So whenever possible, these groups should be provided with the influenza vaccine. Then prophylactic use of neuroamidase inhibitors can be tried if you are strongly suspecting in, say, a nursing home is there, and wherever many elderly patients are living. Then pneumococcal conjugate vaccine to prevent 1/3 of viral pneumonia. This is interesting. What happens? We know that secondary bacterial infections may be the killer. So if we use it, it prevents superimposed bacterial co-infection. That may be one of the interesting things. So vaccines, these 2-3 things are available with us. But apart from this, whatever we have practiced during COVID, that is good hygiene practices, hand washing, wearing mask, avoiding close contacts, they are equally important. So we should not forget it, and we should, in fact, follow this as far as possible. Wherever possible, just do it. And certainly, people ask us, how can we prevent media person and TV persons? They ask, what can we do apart from this? A normal, healthy person, can we do something? Yes, a balanced diet, regular exercise, smoking cessation, they also play equal roles. So it's not directly preventing, but somewhere it helps in preventing the severe forms of infection. So apart from vaccines, we can try all these things also, and we should follow them.
I think it is important to get vaccine. All the chest physicians who are watching, please do get vaccine. We manage all these patients all the time. And I get every year for last many years. And the other thing is, many a times when we examine these patients, we do not wear mask, even if the season is going on. And we think probably we are immune. By the time we get the answer, the test is positive, and then we start putting the mask. I think it is important that we should put mask most of the time when there is a season, at least during season time, and take precautions like washing hand and other things. Another question which I should have discussed earlier, Dr. Nisha, biofire, this has really come up. So is there a role of biofire in diagnosis of viral pneumonias?
So biofire is actually a game changer. That is, it's also known as a pneumonia panel or pneumonia plus panel, which gives you a very accurate and very fast result about in an hour. So the clinician can initiate the appropriate treatment. So here, actually, you get more than 30 microorganisms can be isolated, bacteria plus virus, along with 7 antimicrobial resistant genes. Now here we get a semi-quantitative report. That is that is in copies per ml. The advantage of this is you will get to know if the organism is a colonizer or a pathogen. That is, if the count is less than 10 raised to 3.5, it means the report comes as not detected, which means it is a commensal. If it is more than 10 raised to 5, then it is significant. Now, the advantage is obviously the shorter turnaround time and increased sensitivity. Even the fastidious organisms, especially in case of viral pneumonia, can be detected in this. And in bacteria, we all know that you get to find the bacteria and the resistant gene, which can ease your antibiotic choice. Now, when it comes to viral pneumonia, when the patient has got a viral prodrome with a virus isolated or detected in the biofare, I think you can go for de-escalation of antibiotics. Because as antivirals, you don't have really much option. You can start on oseltamivir depending on the days from the initial presentation, but more application would be in de-escalation of the antibiotics if you are sure that the virus has been detected with the viral prodrome.
My experience is whenever you get a PyFire, if it comes a familiar virus and you are suspecting that it is easier, but it gives you a report, it is adenopi positive, metapneumo positive, you really don't know what to do and you have to really correlate. Probably will need little more experience to figure out the relevance of these virus. But the common virus, of course, they do tell you that probably you're dealing with it. And the constituents, you must know, everywhere the constituents what they're testing may differ also. So Dr. Binu, one of the common presentation, we will spend next half an hour or 40 minutes, and we'll keep on taking, I am asking questions which have been there as a part of this thing as well. So when do you suspect, Dr. Binu, that the patient has developed ARDS?
We're dealing with the symptoms of ARDS.
Yeah, I mean to say that, yeah.
Just like it's more common for the bacteria as virus as for any other etiology, the most common symptom is that it should be within 1 week of a non-clinical insult, or a new or worsening respiratory symptoms. The onset should be acute within 1 week. And the other class are more say signs. That's a bilateral opacities on chest and all. Then the respiratory failure not explained by the cardiac failure and impaired oxygenation. So particular symptom means it should be acute in onset within 1 week, and all other things are basically the signs. And other thing is the relationship between the viral pneumonias and ARDS. The viral pneumonias accounts for approximately 9% of the total pneumonia cases. And there was a landmark study called Etiology of Pneumonia in the Community, that's the EPIC study, which assessed the different etiologies and found that the viral pneumonias, of all pneumonia cases, viral pneumonias accounts for 9%. But in the ICUs, the viral pneumonias accounts for roughly 22%. And however, the proportion of the viral pneumonias leading to ARDS is currently unknown. And some viruses, that's the respiratory viruses, are associated with a high incidence of lung injury ARDS, like the influenza H1N1, we all know that, then the H5N1, then the H7N9, then the SARS and the MERS. And as of course, our COVIDs. These are the viruses which are associated with a high chance of ARDS and increased mortality.
Dr. Tanvi, do you want to add anything to this?
Basically, when we have to diagnose, it's in initial 3 days. First is the diagnosing the patient has viral pneumonia. Second is getting an HRCT chest done. Third will be diagnosing that the patient has severe ARDS. And fourth will be that we have to decide whether to electively intubate the patient or continue with NIV. These are the 4 main steps I would like to elaborate on. Electively intubate and then follow the protocol that for the ARDS, the management has to be very strict. Every hour, minute changes have to be made, and all the changes majorly are in the initial 3 days. Those will only decide how is going to be the outcome of the patient in the later stages. All this also depends how the patient clinical scenario is, whether the patient is aged, immunocompromised, multiple comorbidities. So all this will help to decide us whether the patient is requiring elective intubation or we continue with the management on NIV.
Thank you, Doctor. I will discuss a new definition of ARDS. That there was one definition, AEC definition for many years, and then came the Berlin definition. And now when you say ARDS, of course, in a patient of viral pneumonia, when he develops set of things, then you call it a ARDS. Now, for example, as you can see on this, So first is there should be a risk factor. In our patient, it's a viral pneumonia, but it could be pneumonia, non-pulmonary infection, trauma, transfusion, aspiration, anything, a reason, etiological agent which can result in ARDS. So this in our condition, it could be a virus, severe viral pneumonia. Then is the timing. If you get a symptom, acute onset or worsening of hypoxemic respiratory failure within 1 week of the estimated onset of the predisposing risk factor. In our case, it is viral pneumonia, but it could be anything. It could be trauma, it could be bacterial pneumonia, it could be transfusion or anything, or new or worsening respiratory syndrome. Then the imaging. Previously, we used to say only chest imaging. Now it is included that bilateral opacities on chest radiograph and or computer tomography, that is on the CT scan if it is possible, or bilateral B lines, which you can see on ultrasound or consolidation or ultrasound, not fully explained by effusion, atelectasis, nodule or masses. So that is the chest. So there should be etiology. It should worsening or new symptom within 1 week of the primary illness, and the chest imaging, which is not explained by effusion, atelectasis, nodule or masses, which is confirmed either by CT chest or by the chest radiography or the bilateral B lines or consolidation. Then new thing which is in the new definition is now there is no need of doing ABG. Previously, we used to do an ABG to diagnose ARDS. Now they have included the pulse oximetry. In non-intubated ARDS, that's the terminology now, that when PF ratio is less than 300, if you've done an ABG, if you've not done an ABG, the ratio of SpO2 to FiO2 between 315 to 235 or less than 315 on either high flow nasal oxygen up to 3 liters per minute or NIV or a CPAP with at least 5 centimeter water of end expiratory pressure. So this is the non-intubated ARDS. Then the intubated ARDS is a mild, moderate and severe. The ABG definition remains the same, although they have excluded the PEEP now from the definition. So mild is between 300 to 200, moderate PF ratio between 100 to 200 and severe less than 100. But if you are taking pulse ox, when the SpO2 FiO2 is less than 315, it's a mild. When it is between less than 235, that means between 315 and 235 SpO2 FiO2 ratio is mild. When it is less than 235, it is moderate. And when it is less than 148, it is the severe ARDS. So this is the new definition which is being recommended and probably is being accepted as we talk on the ARDS. So ARDS, when you label a patient on ARDS, you must see all these components because it has a lot of implications, the medico-legal also. So first is there is reason, it is within 1 week, and radiological, and based on the either PF ratio or SpO2 FiO2 ratio, you divide them into mild, moderate and severe ARDS. Now my next question is to Dr. Parvaiz. Dr. Parvaiz, when these patients are there, of course, when there is a patient of hypoxemic respiratory failure, we start with NRBM. Sometimes we give them HFNO or HFN, see what is called, or we give them the non-invasive ventilations. So what do you prefer in such a patient who requires, when you put an oxygen on a mask, he's requiring more than 15 liters and you think of shifting? What's your choice and how do you decide?
So I think this is a very important question, but has to always be answered for a patient individually, given the context of the setting where you are in. And though there are studies that have shown that HFNC is clearly superior to non-rebreathable mask, and the other studies also show that non-rebreathable mask with a nasal cannula may be probably as good in settings where you may not have availability of HFNO, because there may be settings where it is just not possible. But overall, if you talk of evidence is clearly, the trend is in favor of HFNC. But if it is not available, non-rebreathable mask with a nasal cannula may be an alternate possibility in places where the other one is not available.
I think we are in India and we have to talk the availability, because
that is what I'm saying.
Is talking He will not talk about the availability. So if a person requires high FiO2, of course, you will start with a mask and give him high flow. If you have available, HFNO would be the first choice. Till you organize your non-invasive. Now, fortunately, every small center has NIV. And as you organize NIV, if you have HFNO, that will definitely be a first choice in these patients of ARDS and hypoxemic respiratory failure, because their flow requirements are high. And if I'm breathing as a patient at a 60 liters per minute, this 15 liters would not be enough. So that's why you require HFNO, which can give you up to 50, 60, and even more liters per minute of the air mixed with the oxygen, or a pure oxygen. So, or otherwise you can get an NIV. So I'll ask Dr. Salil, so where do you use NIV in these patients of viral ARDS? Dr. Salil, please. I think he's not connected. So, Dr. Parvaiz.
Salil, you're muted.
Oh, sorry. Yeah, Rajesh, I'm there. So,
Yeah,
Rajesh, while I was trying to introduce you, I still remember that you are one of the pioneers of NIV use in India. And I was there in a workshop with you. I've read your book
2001.
also. Yeah, I've read your book also. So the point is, when we have to move to NIV now, it is slightly debatable and tricky thing. And any patient who has a mild ARDS, who is hemodynamically stable, easily oxygenated, and we have no contraindications for use, we can use NIV. These are the areas where we can do it. But we have to frequently evaluate, and we should have a low threshold for intubation. In fact, intubation, as Dr. Tanvi probably was saying, we should be very careful wherever the SpO2 is falling, increased work of breathing, altered mental status, cooling airway secretions. These are some of the things where we cannot use NIV. We have to switch over to intubation.
So, there is a lot of debate whether to use HFNO or whether to use NIV in these patients. One thing is very clear: if the carbon dioxide is high, if the PaCO2 level is high, if it's a patient of COPD developing viral pneumonia, there is no doubt the NIV would score, and patient getting exhausted, NIV would score. But otherwise, HFNO would be a choice. And the problem is not about to use this. We sometimes do not intubate them. And, we've seen during COVID, we keep on seeing otherwise also that the family doesn't want the intubation. The doctor also doesn't want. It is going to cost more in a private hospital. And otherwise, the implications, the managing the chances of nosocomial pneumonia also. So you don't want to intubate. But I think it is important not to delay. See, this is one condition where a lot of people try to delay the intubations, and there are studies for HFNO as well as NIV. If you delay intubation, the mortality is higher if you had intubated them early. I feel if the PF ratio is going below 150, patient on the FiO2 of 0.6, and you're requiring, or let's say you're requiring 100%, your PF ratio is coming less than 100, please intubate them. Because if you intubate late, even after intubation, you may not be able to maintain oxygenation. You will require the rescue measures. So it is very important that you use HFNO and the NIV. If the PF ratio is going down, clinically patient is worsening, or patient is hemodynamically unstable, patient is getting drowsy, please intubate. These are not the patient for NIV. When patient cannot maintain his airway, that means he's drowsy, he's hemodynamic unstable, he's constantly deteriorating, please do elective intubation in these patients. So Dr. Tanvi, once you intubate, what is the ventilatory protocol in these patients? What kind of lung strategy you follow in these patients?
Well, I would like to thank Dr. Amita Madam for giving me opportunity to talk about this very important topic of viral pneumonia and ARDS. So for ARDS, for viral pneumonia and ARDS, we follow the same protocol that we have for all other ARDS patients also. First will be lung protective ventilation. We have to keep a tidal volume between 4 to 8 ml per kg of the predicted body weight if we don't have the actual body weight. Along with that, we have a strategic approach by ARDS NET trial where we have the PEEP and FiO2 table that we can follow. As the FiO2 requirement increases, we will have to keep a PEEP on the higher side. But provided we have good neuromuscular blockade achieved in that patient with adequate sedative and paralytics. Keeping a mild sedation and giving a higher PEEP is going to add to more complications like pneumothorax and pneumomediastinum, which is going to complicate the entire prognosis of the patient. If we talk about the recent ARDS protocol, it talks about the moderate recommendations for corticosteroids. First, for corticosteroids, we need to figure out whether the patient is having only viral infection, viral plus bacterial, and we need to rule out if it is only bacterial.
We'll talk about steroids later, just the ventilator setting.
Okay, so ventilatory strategies. First, ideally, we start with 6 ml per kg body weight, and we have to keep the plateau pressures less than 30 centimeters. And respiratory rate can be adjusted between 16 to 18 to achieve a good minute ventilation for the patient. If the plateau pressures are not being maintained, so in that case, we can lower the tidal volume per 1 ml per kg every hour to achieve the plateau pressure less than 30 centimeters. Permissive hypercapnia, yes, up to at least 64 centimeters of carbon dioxide is accepted. And pH also we can accept up to 7.25. But provided we are following the PEEP inspiratory-expiratory ratio. Lung recruitment maneuvers, there are strong recommendations which are against lung recruitment maneuvers and prone ventilation for more than 12
hours. We'll talk about all those things as we go along. You see, when you have to put these patients on the ventilator, use a mode which your whole department knows very well. There are various modes and people will talk about a lot of modes. Ventilatory, it's a volume control, pressure control. Most commonly use a volume control mode, as Dr. Tanvi has said. And then, the next is the tidal volume. Terminology uses lung protective ventilatory strategy. Lung protective means you do not give too much tidal volume to injure the lung. 4 to 8 or around 6 ml per kg body weight, even if you start with a little higher. And that is a predicted body weight, which can be calculated. For males, the 5 feet is 50. For every other inch, you add 2.3. And there is a formula also. For female, 5 feet is 45.5. For every inch, you add 2.3. So that's how you calculate easily there are studies, you'll be surprised, only 30 to 40% patients, even in the Western, they are following the lung protective strategy. They're giving a higher tidal volume. So in your ICU, if you could do this, you would be doing a lot good to your patients. And PEEP, as she said, to begin with, you can start about 10. And then there are various, which I will ask the other speaker about the PEEP, how to settle down the PEEP in these patients. And plateau pressure, as she said, you should see that it is less than 30. If it is coming more, go lower on the tidal volume. And by doing this, when you give a less minute ventilation, the PaCO2 will rise. And you allow in these patients, that's why the terminology permissive hypercapnia. And you can tolerate up to 7.2. But how will you do it? You keep on increasing the respiratory rate. You can go up to a respiratory rate of 35 to maintain the PCO2 down. And in very rare patients, you should use a soda bicarb. Otherwise, you would not require to use if you're following all these. And as she has said, you sedate and paralyzed in initial 48 hours. Although there are a lot of studies whether to use the neuromuscular drugs or not to use, but now it is recommended at least initial few hours or 48 hours, you must use neuromuscular blocking agents. That is the sort of consensus among these patients. So I'll ask Dr. Nisha about the PEEP setting. So how do you go about setting the PEEP in these individuals?
Okay. Now, PEEP is positive end expiratory pressure. That is a pressure that is needed to keep the alveoli distended at the end of expiration. Now, what is the significance? Because this is the gas that takes part in the gas exchange. So, if the patient is hypoxemic, you need a better gas exchange. So, you need to have your alveoli distended, for which a particular PEEP should be given. But can you go on increasing the PEEP? No. Because in ARDS lungs, you have two types of alveoli. One is recruitable alveoli, the other one is non-recruitable alveoli. Only if you have a recruitable alveoli, you can go on increasing the PEEP. Whereas in non-recruitable alveoli, if you go on increasing the PEEP, it will rather harm the patient. So we have got to find out the optimum PEEP for a particular patient. We have got so many methods, and which method to follow is totally the clinician's call. So first thing is ARD, according to the ARDS niche protocol, we have got FaO2, a PEEP table. So you can set the PEEP accordingly as FaO2 goes on increasing. And the next one is you can do recruitable maneuver. That is, there are also so many methods are there. Most commonly done and most practical one is you go for the incremental PEEP. That is, you go on increasing the PEEP by 2 centimeters water, and then you keep a watch on the PEEP plateau. PEEP plateau should not go more than 30 centimeters. And the recent approach is the concept of driving pressure. So you bring in driving pressure, which is the difference between PEEP plateau and PEEP, which you get from the ventilator. Now, driving pressure should be kept below 70. If it goes beyond 17, it means the compliance of the lung is low, and the increasing the PEEP is going to harm this patient. And then you have a PV loop. That is a hysteresis you get in the ventilator. You can go for the lower inflection point and add 2 to that. You'll get the optimum PEEP for that patient. And also we have esophageal manometry and electrical impedance tomography, all these sophisticated methods. But I think the most practical approach would be to go by the driving pressures. Now, coming to the advantages of PEEP, yes, you can recruit the lung. You can bring down the FaO2 requirement. You can push the intra-alveolar fluid into the interstitium. So are there any trials or studies to support this? Yes, we have alveolar trial, which have shown that higher PEEP have got improved oxygenation in ARDS patients.
Yeah. So you see the PEEP, setting a PEEP, just remember, I have been doing this for the last 25 years, rather more than that. The best way is follow the ARDS-NET table. You know, in the ARDS-NET study, there is a table which gives you how much FiO2 and how much PEEP. So you just, and this strategy has been found to improve outcome. And you can give a higher PEEP in a patient whose FiO2 requirement is high. In those patients whose has a refractory hypoxemia, you could use a higher PEEP. Although there are various methods, there's nothing wrong about it. You can use the best compliance method or use the driving pressure, which she said that you should keep below 15. Driving pressure is that you see a plateau pressure and the PEEP. The difference between them is a driving pressure. If you give a PEEP and the lung is getting recruited, the driving pressure will not rise. So you can give higher PEEP so that the driving pressure remains below 15. But somehow this strategy has not been tested in trials that it improves outcome. So the best would be if you are just a beginner or you are, I mean, that's the common, which most of the world is using even today, is the ARDS-NET table to fix up the PEEP in these patients. Now you put a patient on the lung volume protective strategy. You've suggested your PEEP and you are finding your patient, the saturation is coming 80. His FiO2 is 100 and your saturation is not coming. You know, a lot of strategies have been trying. One of them has been the recruitment maneuvers. And recruitment maneuver is that you give a higher pressure at the end expiratory pressure for a brief period of time to recruit the lung, to open up the lung. But, you know, people have been doing, we also have been doing, but there is a study called ART trial, which showed that if you do recruitment maneuver, there is a increased mortality. So no longer we use this recruitment, except when you disconnect the ventilator or you've done a bronchoscopy, you've done a suctioning. Only under those circumstances, we use recruitment. And that you can do, you give a 40 centimeter or 30 centimeter of PEEP for 30 to 40 seconds. to open up the lung and then come back to the previous settings. But this is normally not recommended. It is only under these circumstances as we talk in 2024. What we do more often is a prone ventilation. And I'm going to ask Dr. Parvaiz in about detail about the prone ventilation. What is the utility of this and how does it help in these patients?
Well, thank you, Dr. Chawla. I think, yes, prone ventilation has come in a big way now. I mean, specifically during the COVID pandemic. For patients who are intubated and have, say, a moderate to severe ARDS, defined as you rightly said, some PA to FI2 ratio of less than 150 or PEEP more than 5. The new ARDS guidelines strongly and unequivocally recommend using the prone position to reduce mortality. So there's a mortality benefit if you use prone ventilation in prone positioning in patients who have a moderate to severe ARDS, which includes the ARDS related to COVID-19. There was also a strong recommendation for starting prone positioning early after intubation in patients who receive mechanical ventilation, and a suggestion for awake proning for non-intubated patients who are either receiving HFN or no for COVID-related acute hypoxemic respiratory failure to reduce the risk of intubation. So there's a mortality benefit in patients who are intubated and a benefit of reducing the intubation risk, not necessarily mortality in those who are awake and are given awake proning. There has been no recommendation definite for patients who have an acute hypoxic respiratory failure not related to COVID-19. That was the recent most ARDS guidelines. So the ATS also gave the guidelines. They recommend that prone positioning for about 12 hours per day in patients with severe ARDS. There's a strong recommendation for that. Regarding the disadvantages of prone positioning, there can be pressure sores, facial edema. Some people have reported hypotension, peripheral nerve injuries, even ventilator-associated pneumonias. They all have been reported, and there have been mitigation strategies for performing that. I mean, using headboards, using maneuvers, pillows under the chest, under the pelvis, in order to repositioning patients frequently, so that you reduce any disadvantage as a result of the prone position.
You see, this is one condition which all chest physicians should learn, because you can even prone a patient who is not ventilated.
Yes.
And we had seen in COVID, although, studies have shown its utility and improved outcome in patients of COVID. Non-COVID, it has not been shown, but this is still a very good modality, even in a awake patient who is on NIV, who's on HFNO, that you can prone them and avoid intubation. But of course, prone positioning, you require 4 to 5 people, and it has a lot of improvement. It improves oxygenation. If you find there is a improvement of 10 millimeter mercury in the PaO2, that means patient had a significant response. And the ProSeva trial, which was one of the very important trial, if the two conditions which have shown improved mortality, one is the ARDSNet and the other one is the ProSeva trial, which showed it improves outcome, it improves mortality. If you've not been doing the proning, please do in your unit, because it's very easy to learn. You require 4 to 5 people. And once you start using it, only contraindication is patient who is in a very high vasopressor or inotropes, or has a spine abnormality. In pregnancy also we've done sometimes. So it is not that you cannot do, but that is a relative contraindications, or patient who's got a high ICP. Otherwise, most of the patients you can do the prone positioning, and it can improve the outcome, because ECMO, which is the next thing which we do in these patients, is not available in almost 90% of the centers, and it's very expensive. Patient can't afford. Ventilator we are doing even in the government hospitals. So learning prone, doing properly prone, so that patient, as he said, does not get sores, because if he starts getting sores, then the relatives will point out to that. So you should be careful, because you can develop the system, you can develop the ring and everything, so that patient does not get these. So Dr. Salil, what are the alarm setting you set up on a ventilator when you're ventilating a patient of ARDS?
Well, Dr. Chawla, before I go to that question, in COVID periods, we have tried this prone positioning in non-ventilated patients. So what happens in our peripheral hospitals where there are sources are less, and in fact, oxygen was also not available sometimes in that period. So these things, they work very well. And in fact, in peripheral health institutions, there must be NIV use, and prone positioning and other things should be learned and tried well. You have asked about what should be the ventilator settings. In fact, it is we should carefully monitor the issues like inadequate oxygenation, high airway pressure, and patient ventilator asymptotic. These are 3-4 things which are needed, and we should take care of these by setting high pressure alarms and low pressure alarms. Tidal volume, you rightly said, we need low tidal volumes, so it should also be set in minute ventilation alarm. And apart from those, we should take care of other regular alarms also, because they are we have to behave like other ARDS patients here.
They are not much different from a normal settings. The alarms in ARDS and viral, they're almost the same what you set in the other patients. The other thing very important, as Dr. Tanvi was saying earlier, now I'm going to ask this question to Dr. Binu. What is the role of steroids, in viral pneumonias, whether to use or not to use? And then I'll tell my recent experience about use of steroids. Dr. Binu, please.
Yes, Chata. Obviously, the thought that steroids in ARDS, like H1N1, MERS and all, routine steroid administration is not recommended due to a higher rate of nosocomial infections. But we have COVID recently, and it changed all these perceptions. Now, we are looking for specific ARDS phenotypes or biomarkers so that we can identify the treatable traits. And these treatable traits in ARDS includes the inflammatory phenotype. There are two phenotypes basically. One is the inflammatory one, and the other one is the immunosuppressed phenotype. If the patient belongs to the inflammatory phenotype, then he is most likely to respond to the anti-inflammatory steroids. While if it's an immunosuppressed phenotype, then the anti-inflammatory agent should be withheld. And several biomarkers or phenotypes, nowadays even AI is being used. And one of the biomarkers under study is the alveolar pro-collagen. It may be an indicator of fibroproliferation. And if it is in large quantities, means that he is a candidate where the patient is likely to respond to treatment with corticosteroids. And another one using AI is that analysis of expired air in ARDS. This is also one of the promising venue of research. And now, steroids, whether to use it in the early stage of ARDS or in the late stage. And we have two distinct stages. One is the early, where inflammation is expected to be the most important. And the other one is the late stage of ARDS, where the lung fibrosis predominates. And in early stage ARDS, it is basically characterized by the major alveolar inflammation. And steroids are theoretically expected to be relevant treatment for ARDS in the early stage. But in practice, the clinical trials has found it highly variable, with favorable in some, neutral in some, and harmful in some others. While in later stages means it's universally accepted that it's in the stage of fibroproliferation, where already the hyaline membrane is present. Here, the steroids have only very little role. As evidence by one of the largest multicenter trial found that there is no evidence for steroids if it is initiated in the late stage at ARDS. That is, the 60-day mortality is almost at par. And now coming to the dose and what type of steroids. Usually, if you are using methylprednisolone, go with a small dose, like 1 to 2 milligram per day, because the high dose, like 30 milligram per kilogram per day, has been found to have no effect on survival. And even our hydrocortisone can be administered as 3 times a day, 1 milligram per kilogram for 7 days. Increased survival has been documented for early ARDS.
Yeah, you see, influenza ARDS used to be a contraindication of using steroids in patients of ARDS. If there are two contraindications, if you see anywhere, it is the influenza pneumonia and the aspergillus. Do not give steroids when they develop ARDS. But after COVID, when you had the recovery trials and they started using dexamethasone, and we all have saved a lot of patients. Recently now we had a lot of patients of H1N1, and I have not been using, but this time I will. It is not based on any scientific evidence, but I have used the steroids in these patients. And I have used in pregnant ladies, I have used in otherwise, and I was able to avoid, they were on a very high FiO2, I was able to avoid intubation. But I have used dexamethasone in all these patients. But I personally feel now I've used almost 20 patients. There is a need to do a trial of using the steroids in these patients and I've used early ARDS. As Dr. Binu is saying, there is no role of these in a late ARDS, because once you use in late ARDS, you will have more of critical illness neuropathy and weakness, and side effects would be more. But you should be very, very selective. Do not make it a rule that you use in all patients of ARDS. Dr. Parvaiz, what's your experience on this?
I would agree with you. Generally, we would not use steroids, but many a times when the patient is crashing, not doing well, I have also used steroids myself. I mean, I have used steroids, and I would say cautiously, yes, to some benefit. But as you rightly said, that we need to have evidence in the form of a clinical trial and come up with evidence. Yes, it is useful. Probably they are useful.
I think so.
The fact that
this is all anecdotal.
Yes, given the fact that we are slowly inching towards the steroids now. I mean, we have some recommendations from IDSA for COVID. We have some recommendations for ARDS use of steroids. So there is a possibility that we could probably be helping some of these patients from getting an intubation or reversing their mortality to some extent.
Yeah. So, Dr. Tanvi, what is the role of pharmacotherapy? Like there are a lot of drugs which are available, like the Avitadil and all these. Do you think they have a role?
Aviptadil, I would like to tell about the history of Aviptadil. It was initially labeled as an orphan drug in 2001 by US, and it is a synthetic form of human vasoactive intestinal peptide. Now, how it works is it binds to the alveolar type 2 receptor cell. On the receptor, it has a VIP2 receptor on the type 2 alveolar cell. It binds to that and it blocks the apoptosis. It also reduces the inflammation and restoring the function of the damaged alveolar epithelial cells. This is what the basic mechanism is. But the studies are usually in COVID patients and in sepsis-related ARDS patients. The recent trial in November 2022 we have, it is published in Critical Care Medicine by Dr. Youssef. The primary endpoint was not achieved. It is a trial of 196 patients where the primary endpoint was alive and free form of respiratory failure at day 60, which was not achieved. Second, we have an Indian study. It is published in European Journal of Pharmaceutical and Medical Research. It's in 2022 of 150 patients. In that also, they have given 3 days increasing dose of drug, in which the primary resolution of respiratory failure is achieved on day 3. And also on day 7, there's 2.6-fold increase in the survival. Now, how this drug is given? It is in a vial, which is 150 micrograms, and the dose increases every day. So on the first day, you give 50 picomole per kg per hour over the period of 12 hours in an infusion. Second day, you use 2 vials, that becomes the 100 microgram per kg per hour. And third day, will make 3 vials of the 150 microgram, which becomes 150 picomole per kg per hour. So the studies have been showing it is not an individual drug which is helping. We have used remdesivir, we have used steroids, we have used prone ventilation. So it is not a standalone solution, but rather a complementary element in the broader spectrum of ARDS treatment. We need more studies where we have 2 different groups where we are just giving VIP, but that cannot be. It will harm the patient. So
yeah, thank you. So, I don't have experience. I have not used this drug, but a lot of drugs have come and gone, but so far there's not substantial trial to show its efficacy. So, when a prone is not working, so what do you do? I think all over the world now we do ECMO, and unfortunately, this is an expensive treatment, not available in most places. So, Dr. Disha, let's hear from you. What are the indications of ARDS, of ECMO in ARDS?
So ECMO is extracorporeal membrane oxygenator. So it has got two configurations basically: VV ECMO, where you use for respiratory failure, and VA ECMO when you have a concomitant cardiac failure. Now, indications as per ELSO guidelines, that is extracorporeal life support organization. So they have come up with indications, which is a compilation of inclusion criteria from CSER trial and EOLA trial, which are landmark trials in ECMO in ARDS. So first indication is refractory hypoxemia, that is PF ratio of less than 150 at a FiO2 of more than 0.9. Or rather, more commonly and more practically used could be a Murray score. You can use a Murray score. So Murray score, it indicates the severity of lung injury. So the scoring is from 0 to 4. 4 parameters are there. First thing is P, then P by F ratio, then compliance of the lung, and chest X-ray also. That is 1 point is given per quadrant infiltrations. So this is in case of refractory hypoxemia. And second indication is in case of decompensated hypercapnia. That is, we already have discussed about ARDS ventilation, where you give a low tidal volume and higher P. So hypercapnia is expected here, which is permissive hypercapnia, but it can't be at the cost of acidosis. So if the PS goes below 7.2 and your respiratory rate is already at 35 beats per minute, so you really don't have anything else to wash off the carbon dioxide. In that case, you can go in for this. And third indication is severe air leak. You have a pneumothorax or a BPF with a pneumomediastinum where you find really difficult to ventilate the lungs. In that case, you can put the patient on ECMO and you can take care of the fistula, because ECMO is not a therapy per se. You are just allowing the lungs to take rest. Meanwhile, you manage the primary insult. So these are the common indications for ECMO. Now, yes, sir.
Yeah. You see, basically, first is oxygen. Then you go on to HFNO, NIV, not working. You intubate these patients. You prone these patients. And if you have available of ECMO, you should put an ECMO if the prone positioning is not working. No, not many centers are doing this, of course. We shift patients many a times from the other centers. My team goes there and we put the patient on ECMO and bring them on ECMO to our center and manage them. And although it is extremely laborious and labor intensive and expensive procedure, but this can be done. As it becomes cheaper, probably more center would be doing it. So let me ask Dr. Parvaiz. So lung transplant has been done in many of these patients with COVID pneumonia. So what do you have to say? Does it have a role? Because we don't hear that much now occurring in patients of viral pneumonia being subjected to a lung transplant.
It happened early on in the COVID pandemic, and especially during the waves when we had a high mortality. And that is the time that patients had very extensive COVID pneumonias. And that is the time people thought that there is nothing happening on mechanical ventilation or even on ECMO. And these patients, some of them did receive a lung transplantation with good initial outcome. So one of the largest European trials in 3 high-volume centers, lung transplantation was used as a rescue therapy in around 13 highly selected patients with ARDS. And they were bridged on mechanical ventilation and ECMO. And between up to 2020 May, 30-day mortality in them was around 7%, and 1 year and 5 year survival was 71% and 54%. But what is important and what is critical, that these patients had to be selected very carefully and meticulously. And something called exceptional lung allograft score, ELAS, was approved for ARDS patients who were on mechanical ventilation or on ECMO, which includes most of these. You have to have a lack of clinical improvement for about at least 2 weeks, even when patient is on ECMO or mechanical ventilation. There has to be an absent significant ECMO-related complication, which means there is no major bleeding, there are no emboli. There has to be a preserved cardiac function, a preserved liver function. A mild renal function is not considered as a contraindication for lung transplantation. And there has got to be an absence of an extrapulmonary disease, a neurological disease, or an untreated or an uncontrolled infection. So if a patient is selected well, and even in acute settings, and if he is not doing well, lung transplantation remains as one of the rescue therapies. The other time that lung transplantation might be required in a patient may be once a person has recovered from largely from the acute setting, has developed a post viral illness, fibrosis, and it has been quite extensively seen in some patients that there is this extensive fibrosis. That is the time, if they develop a respiratory failure, that is the time they may be considered for lung transplantation.
Yeah, there's a question asked by Dr. Pooja, and there is a question asked by Dr. Shahbaz. What are the prognostic markers of viral pneumonia, and which viral pneumonia has the worst prognosis? Dr. Shahbaz has asked this question.
So you want me to take it?
Yes, please.
Okay, so which viral pneumonia has the worst prognosis? I think the worst probably is with Ebola, and that is nearly 100% lethality. Hantavirus does have a high mortality. SARS-CoV-2 had a high mortality. MERS coronavirus had a high mortality. Of the influenza viruses, if you talk of the subspecies, the H3N2 has a higher mortality because it affects the older people. Extremes of age, once you are having you have somebody at the younger as you rightly said, I mean, somebody who's very young and somebody who's very old, they have a higher risk, and a higher mortality is there in the higher age group. If you have an underlying comorbidity, as you say, diabetes, cancer, immunosuppressed state, chronic cardiac or chronic respiratory illness, all these are pooled together and can be risk factors. Pregnancy remains a high risk factor for developing an adverse outcome of viral pneumonia. And the second question was regarding
prognostic markers in viral pneumonia.
I think prognostic, these are factors. These actually tell you whether these patients are going to do well, and any of these factors present in the person would probably indicate that he's not going to do well.
So, Dr. Tanvi, there's a question from Praful Rajput. What is the role of cytological evaluation, the evaluation of viral pneumonia?
Cytological evaluation comes in the later role. So first we are going to send initially nasopharyngeal swab. Later, see, these are of mainly used in immunocompromised patients where the patient is on NIV or high flow mask or NRBM, and patient is a case of any organ transplant where we are suspecting that the patient is having pneumonia. It can be a viral pneumonia. So in those patients, we may do bronchoscopy, we may see inclusion bodies, we may even plan a biopsy and see inclusion bodies in them. So cytology, doing CMV, viral load is also of importance, but even studies are showing that CMV viral load, according to every patient and what is the background clinical scenario of that patient, we can decide whether the patient is having CMV infection or not.
Yeah, basically, most of these studies, the culture takes about 15 days. They have no role. And similarly, all these tests have not been found to have a specific, no finding which will tell you that the patient has a particular viral pneumonia. There's the same question asked by Dr. Charu, that what is the role of blood culture in workup of viral pneumonia? Dr. Nisha, you want to take up?
If there is a viral prodrome and if it is in the initial state of illness, then I don't think a blood culture would yield anything. But if you're suspecting a secondary bacterial infection, then yes, you can go for with maybe hemodynamic instability. Then you can go for a blood culture workup where you might get a bacteria.
There is
because viral cultures are also, but it is not commonly used
blood
because
culture
of time
may not have a role that much.
Blood culture doesn't have a role.
Yes, Dr. Parvaiz, please.
Yeah, I mean, I agree with Doctor. Blood culture does not have a role. I mean, we generally isolate the viruses and in the form of antigens from various body fluids, be it the nasal swab, be the bowel fluid, or any other fluid. That is where you actually derive, or whether you do it a nucleic acid amplification or you do a culture. As you rightly said, that cultures take so much of a time and they don't have a great clinical utility.
Dr. Salil, is there which is more specific, CRP or procalcitonin? Koil Verma has asked from West Bengal.
CRP has supportive evidence that it can be a viral pneumonia, but procalcitonin, it rules out at least bacterial infections. So both are supplementary investigations with us.
So, this is another question asked by Dr. Tridip Chatterjee from Maharashtra. Dr. Parvaiz, can viral pneumonia cause long-term health problems? What are some of the potential long-term complications?
So yes, I mean, the best experience probably is for SARS-CoV-2 COVID. We have found that there can be pulmonary and non-pulmonary complications. In the pulmonary complications, we have seen that many of them can persist with lung fibrosis, which can reverse, which can be static or even progress into a chronic fibrotic lung disease. That's one. But there can be non-pulmonary complications as well. There have been chronic fatigue syndrome has been described. Long COVID has been described. People have come with brain fog, various mental difficulties have been reported. So yes, the short answer is yes, there can be long-term complications specifically after COVID.
So Dr. Binu, there's a question that how we differentiate between COPD and ARDS, respiratory failure. I think you have to be a chest physician. Refer to chest physician. That is, if you have a difficulty in differentiating. Dr. Binu, is he there?
ARDS can occur in due to any cause. Maybe in the respiratory failure due to any cause. Maybe an exacerbation of COPD leading on to ARDS is one such cause. So there is little that we can differentiate between an ARDS and a COPD. But what we can say is that ARDS can occur due to any etiologies. And one of the diseases which leading on to ARDS may be COPD acute exacerbation leading on to respiratory failure and eventually ARDS.
Yeah. Dr. Sanket has asked from Maharashtra, Mumbai. So I'll ask Dr. Tanvi to answer this. What are the unique characteristics of influenza pneumonia? How does it differ from other types of viral pneumonia?
Influenza, usually there will be a prodrome. It will start from the upper respiratory symptoms with cold, throat irritation, dry cough specifically, how you distinguish it from bacterial pneumonia, where we usually ask the color of the sputum, severe weakness, there can be confusional state, hypotension, and acute severe breathlessness.
Yeah, I think it's not very easy to differentiate, but the upper respiratory tract, the common cold is basically what you get in influenza more often. And otherwise, it's very difficult to differentiate between various viruses. All will present with upper respiratory tract symptom, most of them. So I think most of the other questions we have answered, and we have just 7 minutes left. So I'll just summarize what we've talked about in last 2 hours, that, viral pneumonia, we are recognizing more, and they are causing the mild illness to very severe illness. Although influenza and the COVID, these are still the common viral pneumonias, but others do occur, and we do not have many tests to really diagnose them. But I think with time, we will have the diagnostic test for other viruses also. BioFire can point out toward the possible etiological virus in your patients. As far as the clinical features are concerned, they usually present with upper respiratory tract symptoms, but many a times it is difficult to differentiate clinically based on the history and physical examination, whether it is a viral pneumonia or bacterial pneumonia. Blood test they will usually may have normal blood counts, and the CRP could be high in both viral and bacterial. Procalcitonin most of the time would be negative in the viral illness. As far as the X-ray chest, it can vary from a normal X-ray with a severe symptoms to a very abnormal X-ray with bilateral shadows like ARDS, or there could be a lobar consolidation, interstitial pneumonia, bilateral effusion. So it can present with varied presentations, which can be, even if it's a normal X-ray, you could do a CT, and many a times you could diagnose that the patient has pulmonary shadows in the then the most of these viruses, they have a single organ failure. They predominantly present as ARDS, and we talked about the ARDS new definition before labeling, you should know, and it can also present with multi-organ failure like any of the bacterial pneumonias. The diagnosis, as I said, the RT-PCR is available. We can get and gives you, or the rapid antigen for COVID pneumonia. And there are, for other viruses also, tests are available to diagnose them. Then the management, if these patients develop hypoxemia, you have to follow like in any other pneumonia or any other condition where a person develops ARDS. ARDS does not differ. The management of ARDS does not differ from the bacterial or the viral pneumonia. The management is sort of the same. You try the NIV in a very, very mild patients. If the PF ratio is less than 50, you should start thinking whether I should intubate these patients. And you intubate and paralyze them and sedate them for first 48 hours. You ventilate them with a lung protective strategy with low tidal volume ventilation. You do not try recruitment maneuver if the patient is not responding and he has developed refractory hypoxemia. You should try ECMO. Steroids may have a role in early ARDS. They definitely have a role in COVID-19, but we need a study for the influenza pneumonia. As I've been talking, I'm getting the message there are 23 more questions to answer. So we'll see if we can take them as we go along there, just extracting these questions. And if the prone ventilation is not working, ECMO is a modality which could be used in these patients. And eventually, some of these patients may be candidate for lung transplant, which although expensive, but as many of the people who are watching us are youngsters, they are going to see many of these patients eventually getting lung transplant. Fortunately, when we were treating COVID, we thought we will have many patients suffering from fibrosis. But fortunately, this was a regressive disease. Most of the patients who had bilateral fibrosis on a high oxygen we discharged, then they are running and they're running marathon. So this is a good news because many of these COVID-19, I think all of you must have experienced, recovered, and they hardly have any, even on the lung function, they have a normal spirometry. Very few of them will have some derangement in the diffusion. So should we take some more questions? Dr. Parvaiz, I'll ask Dr. Parvaiz.
As you
because
please.
He had to go somewhere, still he stayed on.
No, as you please, no worries. As you please.
Yeah. So there are... what are the common causes of viral pneumonia in immunocompetent adults? I think we have talked about this. Which vaccines helps against viral pneumonia? We have talked about, but Dr. Parvaiz, you can talk about again. Somebody wants.
So the vaccines we have against pneumonia causing viruses are flu vaccine. We have the influenza vaccine. We have now RSV vaccine is being introduced. It's not introduced as yet, but is recommended for older adults. And one of the two vaccines that are available is available for pregnant females, also given at 32 to 36 weeks of gestation. And if you want to actually prevent, there is another passive immunization for children in the form of monoclonal antibodies, either palivizumab or nirsevimab, that can be given. Then for SARS-CoV-2, for COVID-19, we have a vaccine, and then that is pretty much all that we have in terms of vaccines available for. Then we have vaccines for measles, mumps, rubella, and they can at times cause pneumonia, and they can be used as a part of the universal immunization vaccine.
Dr. Durga is asking Dr. Salil, this question for you. What is the role of sputum for gram stain?
Yes, sometimes the bacterial infections are also accompanying. Most of the time it can be there. So we should rule out that, and that's why the gram staining is being done. So if bacterial infections are there, we can treat them accordingly.
So Dr. Tanvi, there's a question that what are sign and symptom of respiratory failure? So you need to tell about hypoxemic as well as hypercapnic respiratory failure.
In hypoxia, the patient will have increased use of accessory muscles. The patient will be getting fatigued. There will be severe hypoxia, which we can see as an ABG, as well as pulse oximetry findings. Work of breathing will be more. But when we are seeing that the same patient is going into a state of fatigue or respiratory distress or failure, in that the use of accessory muscles will be there, but patient might have flaps, patient will be getting exhausted, ABG will show more of respiratory acidosis with increased in carbon dioxide levels, hypotension will be there. So these are the findings that we see that the patient is going into respiratory failure, and that indicates that the patient has to be taken for intubation.
So there is a question I'll ask Dr. Parvaiz. This is an interesting question. Is a Sumriddhi call from Chandigarh. Is oseltamivir indicated for all viral pneumonias?
The answer is no. I mean, its efficacy has been proven only in influenza pneumonia. However, it is very usual for people to give oseltamivir in every suspected viral infection till your influenza test turns out to be negative.
So I think you all have done wonderful. So I would like to thank. There are questions, but we have answered most of the questions. Dr. Parvaiz, Dr. Salil, Dr. Tanvi, Dr. Binu, Dr. Nisha, and the most of, I cannot stop saying, Dr. Amita, who has really organized every other day. She's organizing a CME or a conference or involving youngsters. That's really I liked. And there was a mix of senior, very senior, and very young. And that's the way it should be. And I thank all of you. And it's 10:30, and we close with thanks to everyone and all of you. Good night, and take care of yourself, because viral pneumonias have killed a lot of our friends. So please be careful when you manage all these patients. Thank you very much.
Thank you, Dr. Chawla. Thank you for that moderation, and thanks ICS for the opportunity.